Well, thanks for coming today. My name is Matt Smith. I'm one of the ear, nose, and throat physicians here at Cincinnati Children's within the department or division of pediatric otolaryngology. And what we're going to talk today about are things that are pertinent to you, which is what do you need to know for your pediatric boards in regards to ear, nose, and throat issues. So, brief outline of what we're going to talk about today. Probably the most common thing that you'll see in the clinic, which is acute otitis media, and then we'll talk about some complications of acute otitis media, auricular hematomas in regards to nasal problems, sinusitis, as well as nasal trauma. We'll then talk a little bit about problems that you might run across within the throat, such as peritonsillar abscesses and such, and then we'll end on talking about airway disorders. So starting off with a brief question, 2-year-old child with trisomy 21 has a history of recurrent ear infections. You saw him 3 days ago and prescribed high-dose amoxicillin at 80 mg per kg per day. Today he started having new drainage from the ear, continued fussiness, and frequent wakening at night. The eardrum you are unable to see due to all the drainage that was there, so you decide to discontinue amoxicillin. What would be the next best course of action? Would it be to A, administer IM ceftriaxone, B, administer 1 dose of IM ampicillin, begin topical fluoroquinolone drops, begin Bactrim, or refer for an urgent ear tube placement? And the board answer would be administer IM ceftriaxone. Starting off talking about acute otitis media, we have that nice picture of that bulging eardrum with purulent material behind there. It's essentially just an infectious or inflammatory condition of the middle ear space. Factors that can contribute to this are upper respiratory infections and eustachian tube dysfunction, and that's primarily why we end up putting tubes in kids, is because of problems with the eustachian tube clearing that middle ear effusion. The thing that's important, and it's something that we always talk to parents about, is aeration is necessary for the proper function of the middle ear space. And what I mean by that is the eustachian tube allows aeration of not only the middle ear space but the mastoid cavity as well. When air is not allowed to get into this area through various types of obstruction, then this can cause some negative pressure, some edema, and then eventually bacterial infections. The middle ear space is a cavity within the skull. It's mucosal lined, and like I said before, the eustachian tube connects it to the back of the nose. So talking a little bit about eustachian tube dysfunction, children, especially when they're born, have short, narrow eustachian tubes, and as you get to be about 5, 6, 7 years of age, it gets to be in more of an adult position where the tube itself is a little bit bigger in diameter. It's a little bit more vertical, which allows gravity to help drain this fluid a little bit easier. Particular importance are kids that might be more at risk for eustachian tube dysfunction, and especially if kids have a history of a cleft palate or a submucous cleft. One of the muscles that helps to open the eustachian tube, the tensor veli palatini, it's not able to function as well as it normally would, and so because of this, then it leads to problems like we talked about before: inflammation of the mucosa, obstruction, infection, other things that especially with kids who get recurrent ear infections, where risk factors for that would be allergies, environmental irritation such as tobacco smoke, or even sometimes immotile cilia. Another way that the eustachian tube can get blocked sometimes is if the adenoid tissue at the back of the nasopharynx is significantly enlarged, and so in those instances sometimes we will end up removing the adenoid tissue as well when kids have been getting recurrent ear infections. So, like we talked about before, risk factors for acute otitis media: smoke exposure, possibly family history. There's been some note with people who have either anatomic problems and or predisposition to eustachian tube dysfunction can be passed on from family members. In larger studies, it's been shown that Babies who are on formula rather than breast milk potentially might be more at risk for acute otitis media. Also males, large number of siblings in daycare, and mostly with the large number of siblings in daycare, it's exposure, exposure, exposure. So the more likely a kid is to be in an enclosed space and exposed to others that might get infections, they themselves will be more at risk as well. Certain high-risk groups include kids with trisomy 21, immune deficiency, Native Americans. They have a large population of people with chronic ear problems, and those that we mentioned before, such as patients with cleft palate or craniofacial abnormalities. Possible risk factors, which are less definitive, are possible food allergies as well as gastroesophageal reflux disease. So the diagnosis is fairly straightforward. Basically, you'll see a bulging tympanic membrane. Typically, it'll look like there's purulent material behind there, and or a thickened eardrum with intense redness of the tympanic membrane. Sometimes kids will have new onset otorrhea, especially if they've had a spontaneous perforation of the eardrum itself. Something that is not acute otitis media, so just because you see middle ear effusion in there, if they don't have what looks like a red bulging eardrum and they don't have redness and fever to go along with this, then it's likely not acute otitis media, and it might be more something like chronic acute otitis media, chronic otitis media with effusion, but it's not necessarily infected. The other thing is, if you don't see a middle ear effusion, it's definitely not acute otitis media. There has to be an effusion present. So the typical culprits for otitis media will be either strep pneumoniae, which on gram stain will be gram-positive cocci, Haemophilus influenza, which will be noted by gram-negative coccobacillus, as well as Moraxella catarrhalis. Those are your three main, most common organisms that can cause acute otitis media. So the standard approach for prescription antibiotics for severe, whether it be unilateral or bilateral acute otitis media, child greater than 6 months with pain for more than 48 hours, fever, or kids who have non-severe bilateral acute otitis media in young children, so less than 24 months, even if they just have mild pain and a low-grade fever. If you see it, the dictum is prescribe antibiotics. There are certain groups in which watchful waiting could be employed. So kids who are 6 to 23 months with either mild otalgia or a low-grade fever, you could think about watchful waiting, but if they're not getting better within 48 hours, then we would recommend using antibiotics. In older kids greater than 24 months, same thing. If they're not having significant problems within the first 2 days, you can consider watchful waiting, but if it gets longer than that, then antibiotics are recommended. So which antibiotic? First line is high-dose amoxicillin, so 80 to 90 mg per kg divided into twice daily dosing. Second line would be adding a beta-lactamase coverage, such as Augmentin. Others include ceftonir, cefuroxime, clindamycin, ceftriaxone. And if things are not improving within approximately 3 days, we would recommend changing the antibiotics. So when to refer to someone like myself? If there are any complications with the acute otitis media, so multiple antibiotic failures, evidence of mastoiditis, which you're seeing here in the picture, that bulging fluid and collection behind the eardrum there. Subperiosteal abscess, which also is seen here in that picture, which is that thick fluid behind the ear. If you're seeing any type of paresis or paralysis with the facial nerve, meningitic symptoms, this would be less seen in the clinic typically, but if there was imaging and there was evidence of epidural, subdural, or brain abscess, those would obviously be reasons to refer to an ENT as well as venous thrombosis. So when we are evaluating for ear tubes, basically our thing is approximately 3 to 4 ear infections within a 6-month period, along with seeing evidence of middle ear fusion, and that's typically what our criteria are for recommending tubes within kids. So like we talked about, you can have some complications of acute otitis media, and those are typically broken down into intratemporal or extratemporal, with the extratemporal broken down into extracranial and intracranial. So acute mastoiditis is most common intratemporal complication. Basically what will happen is the middle ear infection will extend into the mastoid, which will then cause a coalescence of the mastoid cells and typically then form an abscess. Kids will present with ear pain, fever, obviously the otitis media, and you'll notice post-auricular edema or redness. In of particular importance, the mastoid will be very tender. You might see the ear bulging out, and you might even notice some ear drainage or lymphadenopathy around there as well. This can be confirmed by a CT scan, although you don't always have to get a CT scan, as this can be a clinical diagnosis. Treatment is typically IV antibiotics. We will go in and do a myringotomy and put an ear tube in, and at that same time we'll suck out that fluid and send it for culture. If there is any associated abscess, we might or might not decide to perform a mastoidectomy, and that's a little bit of a controversial topic, as it's really based on the clinical symptoms and the treating physician's opinion on how bad that is. But at the very minimum, IV antibiotics, culture of the fluid, and placing an ear tube. So our division published a paper a few years ago in regards to what is best practice for acute mastoiditis. And so you see in here at the top the acute mastoiditis. Is there a suspected intracranial complication? If there is, we'll get imaging and then proceed kind of what I said before, ear tube, simple mastoidectomy, meaning just to drain and remove that bone on the outside and do IV antibiotics. If it's uncomplicated, then we might just do ear tube and IV antibiotics. If kids aren't improving, then we would proceed to doing a mastoidectomy. If there is a subperiosteal abscess, meaning that it wasn't necessarily into the mastoid itself, but there had been a formation of an abscess on the outside of the bone, recommendation would be to place an ear tube, drain the abscess, and IV antibiotics. And again, if there's a poor response, then proceed later to a simple mastoidectomy. Meningitis is the most common intracranial complication of otitis media, and needs to be something that's always on the radar when kids come in with otitis media and look sick. So checking for fever, irritability, lethargy, nuchal rigidity, headache, vomiting. Diagnosis would be on lumbar puncture, and if there were any other intracranial processes, you may consider getting an MRI. Treatment at that point would be IV antibiotics, along with doing a myringotomy, placing a tube, and getting a culture of the middle ear fusion that's there. At what point that the children are stable, we recommend getting a hearing test, just because one of the complications of meningitis in children can be labyrinthitis ossificans, and that can be as a result of meningitis. The bone within the temporal bone, specifically the cochlea and the labyrinth, can get very thick and then lead to permanent sensorineural hearing loss. Another thing that we will see as a potential complication of otitis media, the fusion, is after the otitis has resolved, if there is any type of perforation within the middle ear space secondary to that negative pressure, it can suck some of the epithelium from the ear canal into the middle ear space, which can then lead to the formation of what's called a cholesteatoma, and all it is a fancy word for skin in the middle ear space. And so what you'll see is possibly a pearly mass behind the eardrum, and what it consists of is keratinized debris. Kids will typically present with persistently draining ear, at which point we would recommend you referring them to an ear, nose, and throat physician. So next clinical scenario is you have a 5-year-old who underwent ear tubes for chronic otitis media diffusion in the past, who presented with 3 days of bloody otorrhea and nasal congestion. When you look in the ear, it shows a lot of bloody drainage and maybe a large erythematous mass. The most likely cause of the otorrhea is rhabdomyosarcoma, eosinophilic granuloma, otitis media, cholesteatoma, or a tube granuloma. And the answer would be a tube granuloma. So sometimes the tubes themselves can rub on the eardrum and initially form some granulation tissue around there. And so typically kids will present with some bloody drainage, and you'll see a heaping mound of granulation tissue over the ear tube. Here on the right is a video of us doing a tympanostomy tube placement in the OR. On the left, there's some pictures of some various ear tubes that we use, and what we will do in that setting where there is a granuloma is either pluck the granuloma out and treat with some Ciprodex, which is an antibiotic and steroid drop, and or at some point, sometimes we end up actually removing the ear tube itself, letting some of the granulation tissue and inflammation calm down, and if the child needed another ear tube in the future, switch to a different ear tube at that point. But if you notice that in the clinic, you can send them over our way. There you see the tube finally being placed in with direct access into the middle ear space. Other complications from ear tubes sometimes is simply just post-tympanostomy tube otorrhea. Usually it's sequelae of upper respiratory infection, and we will tell our parents that if they notice any otorrhea from the ears, to just go ahead and treat with Ciprodex drops, 4 drops twice a day for a week. If after a week they're still having drainage, we'll have them come in and see us, at which point we'll culture the ear drainage, and if so, treat them with oral antibiotics. Usually Pseudomonas is the most common etiology of this, so it responds quite well to the Ciprodex drops. Other things that might be in the differential for the otorrhea, like we talked about before, cholesteatoma or tube granuloma. So next question, a 13-year-old wrestler comes to the office with an injury to the right ear. He reports he struck his ear on the mat during practice, and it swelled up thereafter. He was not wearing a protective headgear on the right. You note that the right external ear is markedly swollen, as you can see in the picture, and the normal architecture of the pinna is distorted. Eardrum's intact, there's no drainage. He basically just has pain and tenderness to the external ear. So what's the next step in treatment? Is it to A, apply a pressure dressing over the ear, B, apply ice packs, C, aspirate the blood from the hematoma, D, prescribe Tylenol, or E, prescribe antibiotics? And the answer would be C, aspirate the blood from the hematoma. This is something that can eventually form what's called a cauliflower ear, which you can see here in the picture to the right, if you don't adequately drain the hematoma. Typically what we'll do is we'll needle drain the fluid out of there and then put some bolstering sutures and packing on the outside of the ear in order to prevent that fluid from reaccumulating. What will happen is if you don't do this, you get some fluid between the epithelium and cartilage, and eventually what happens is that cartilage just degrades and forms into scar tissue. Next question. Mother brings her 3-year-old daughter in for evaluation. She placed her in childcare about a week ago. Over the past 3 days, she's had some yellowish rhinorrhea, cough, otherwise as well. Temperature 37.3. You note that she has drainage from the nose, but other than that, she appears healthy. You order a sinus radiograph, which shows bilateral maxillary mucosal thickening with a pacification of the ethmoid sinuses. What is the most appropriate next step in therapy? A, amoxicillin, B, azithromycin, C, IM ceftriaxone, D, observation, or E, Bactrim. The recommendation would be observation. So the ears and the sinuses have a lot in common in that they're lined by the same type of epithelium, and the same pathogens which cause otitis media are the ones which will typically be involved with acute sinusitis. Now typically about 90 to 95% of acute sinusitis will be viral in origin. a consequence of the initial viral sinusitis can be bacterial proliferation, and like I said, S. pneumo, H. flu, M. catarrhalis can all be a result of that. I know on the question stem it had mentioned about an X-ray being performed. X-rays aren't necessarily that useful or common anymore. Typically this is a clinical diagnosis. If there is any concern, CT scan without contrast will typically be performed if there is any further concerns or about complications from the sinusitis. So the maxillaries are fluid-filled at birth along with the ethmoids. Sphenoids actually are absent at birth, and the frontal sinuses are also absent at birth. The maxillary or the cheek sinuses will become air-filled between 0 and 3 years of age, and then grow in size between 7 and 12 years of age. The ethmoids, which are the honeycomb sinuses between the eyes, will fill with air gradually, and they become fully developed by 12 years of age. The sphenoids, which are kind of in the center of your skull, will start to develop around age 3 and become full size by 18 years. The frontal sinuses will first be visualized and start to pneumatize around age 2, and typically aren't fully developed until late teenage or early adulthood. So acute sinusitis, high fever, sometimes some pain over the maxillary sinuses, purulent nasal drainage, those will be signs of acute bacterial sinusitis. Like I said before, initially it's a viral URI, impairs ciliary function, leads to inflammation and edema, and then bacterial superinfection. About 80% of kids will be able to clear their sinuses quite well and not necessarily need any type of treatment. But if it's lasting longer than 10 days, then you need to consider acute sinusitis. Subacute sinusitis would be symptoms persisting greater than 1 month, and chronic sinusitis greater than 3 months. Chronic sinusitis in kids is not necessarily as well understood as it is in adults. Typically it's linked to allergy. They will have nasal airway obstruction, headache, cough, sometimes bad breath, intermittent fevers, irritabilities, and these will be kids that typically you'll notice some association with a particular season. Non-surgical management are antibiotics, nasal steroids such as Flonase or fluticasone. We are big proponents of saline within the nose and irrigations, along with humidification and humidifiers at the bedside. If kids are frequently failing treatment, then we will see them in the office. Typically we'll get an allergy evaluation. One thing that's important to rule out is cystic fibrosis, and making sure that the sweat chloride test is negative, and making sure that they also don't have primary ciliary dyskinesia. An immunology screen is appropriate as well, just to make sure that there's not any underlying immune system problems. And sometimes for very recalcitrant cases, we will do a little bit more in-depth workup for GERD, as this can sometimes lead to sinusitis type symptoms. So like I said before, when to image, it's a clinical diagnosis in kids. Plain films are not helpful, and the only time to get a CAT scan is either if you're worried about a complication, or on our end if we're planning to go in and do surgery and we want to have a roadmap of the sinuses. If kids present with only one-sided rhinorrhea, and it's always the one side, you always have to suspect a foreign body. Typically it'll be foul smelling, sometimes blood tinged, and as soon as you look in, you typically will see, as you see here, a nice green toy within the left nasal cavity. Another more rare diagnosis that can present later in childhood is unilateral choanal atresia. Typically the bilateral ones are picked up at birth, as kids are obligate nasal breathers, but unilateral choanal atresia sometimes will present later in life, around 4, 5, 6 years of age, when parents say that their kids just always have drainage from the one side of the nose, and then we do further workup and we realize at the back of the nasopharynx there's no opening. Another common thing that we'll see within the nose are nasal polyps. Anytime you see nasal polyps in a child, you have to rule out cystic fibrosis. Another thing that sometimes we'll see in kids is association of asthma. Samter's triad is nasal polyposis, asthma, and aspirin sensitivity. There's some other differentials that are listed there as well. The key for allergic fungal sinusitis is on CAT scans. Within the sinuses themselves, you'll see different densities within the maxillary and or ethmoid sinuses, and it's essentially due to the iron deposits within the fungus in the area, and when you're actually in the OR and draining it, it almost looks like peanut butter coming out. So just like with acute otitis media, you can have some complications of sinusitis. It's been quoted around 1 to 3% will have some type of orbital or intracranial complications. It's particularly important to understand the anatomy of the sinuses, as that will dictate kind of what complications you might have from each of those sinuses. As you can see here, here's a picture looking at the ethmoid sinuses in particular. You can see how closely they are associated with the eyeball itself. The medial orbital wall is also known as the lamina propria, and the reason that it's named that is because it literally looks like a piece of paper and it's that thin. Because of that, you can very easily get intraorbital complications from acute sinusitis. These can be these can be manifested as periorbital edema, proptosis, along with erythema overlying there. They might not even have any signs and symptoms of sinusitis if that part has gotten better, but you'll notice it with the complications. So the complications can be split up into preseptal, orbital, subperiosteal, orbital abscess, or cavernous sinus thrombosis, and those are Chandler's classification of the of the 5 different types of complications from acute sinusitis. Periorbital cellulitis or preseptal cellulitis is the most common, and basically it'll just present with a swollen upper eyelid. There's no significant proptosis, there's good extraocular movements, there's no loss of visual acuity. With orbital cellulitis, you will have some proptosis, you might have some extraocular movement limitation, but visual acuity impairment suggests that it's not orbital cellulitis but something worse, because their visual acuity should be intact. With a subperiosteal abscess, you'll notice significant extraocular movement impairment. You might notice some visual acuity changes as well, and you'll definitely notice significant proptosis. Subperiosteal abscesses, if they are of any significant size, will typically be drained in the operating room. If there is complete ophthalmoplegia, severe proptosis, impairment of vision, that you have to think of as orbital abscess, and this can either be extraconal, meaning outside the orbital cone or orbital fat, or intraconal, meaning that it's within the extraocular muscular cone. The worst is cavernous sinus thrombosis. This will typically be manifested as picket fence fever, sepsis, and there is rapid progression to blindness. There's a significant mortality associated with this, and typically the first nerve that you see go is the 6th nerve. So just in summary, acute sinusitis with any type of complication, IV antibiotics, nasal saline irrigation, call ENT and ophtho. So next, a 15-year-old baseball player was struck in the face by a pitch. He reports he had profuse nasal bleeding after the trauma. His nose is swollen, it's hard to breathe from one side of the nose. You look in there, it's edematous. There's some bruising underneath the eyes. You can see a clot visible in the left. The right side shows a purple swelling on the medial aspect. What is the next step in treatment? Apply a warm pack, pack both nostrils, apply phenylephrine nose drops, prescribe prophylactic antibiotics, or refer him to an ENT. Answer would be call us. One thing that we worry about, just like we talked about with the ear and there being auricular hematoma, is a septal hematoma. Looking in the nose here on the right side, which is the left side of the screen, you can notice a red area that's kind of bulging out that looks different from the left side, and that would be evidence of a septal hematoma. those need to be drained immediately so that you can prevent any further septal cartilage deterioration. If there are any facial fractures suspected, get a CAT scan, as well as you would have already called us at that point. And if there's any significant clear rhinorrhea, you'll want to collect that and send it for beta 2 transfer. If kids, particularly adolescent males, those are the only ones that will present with this, recurrent epistaxis, and typically it'll be unilateral, but it can be bilateral. But in an adolescent male who's having recurrent epistaxis, you always at the back of your mind have to be thinking of a JNA, or a juvenile nasopharyngeal angiofibroma. If you're having a kid, particularly adolescent male, who has recurrent epistaxis, send them over to ENT so that we can make sure and do a scope and make sure that there's no masses back there. So next question, 15-year-old male presents at clinic with high fever, bilateral cervical lymphadenopathy, fatigue, and headache. There's symmetric enlargement of the tonsils with exudate present. Monospot and rapid strep are negative. What is the next step in clinical management? A, repeat the monospot. B, treat with penicillin. C, observation. Or D, obtain EBV and IgG titers. And the answer is D. The reason being is the monospot is not necessarily that sensitive or specific of a test, and if you're suspecting infectious mononucleosis, we would recommend getting EBV, IgM, and IgG titers. With peritonsillar and retropharyngeal abscesses, these can both be complications of acute tonsillitis. They'll both present with fevers as well as difficulty swallowing. With a peritonsillar abscess, you'll notice typically either the soft palate or one of the tonsils bulging from one particular side. Retropharyngeal abscesses are more common in kids less than 5 years of age, and that's because of a lymph node within the retropharynx called the node of Rouvier, which tends to get infected and then will present with a retropharyngeal abscess. With a peritonsillar abscess, typically fever, sore throat, sometimes trismus, and typically trismus is the identifying feature because they have difficulty opening their mouth. That would warrant a referral to ENT so that we can drain that abscess. Imaging is not typically needed as this is a clinical diagnosis. You'll notice uvular deviation to the opposite side. At the bedside, we typically will needle aspirate and then send home on antibiotics such as augmentin or clindamycin. If kids get 2 or more peritonsillar abscesses, that is an indication for a tonsillectomy in the future. Retropharyngeal abscess, the key here is going to be the diminished neck range of motion, especially on extension. You can get an x-ray which can show widening of the retropharyngeal space. Also CT scans typically are useful in this as well. Again, surgical drainage, this is done typically in the operating room along with either Unison, clindamycin, or augmentin. Switching gears to the airway real quick as we finish up, although it's not a golden rule, usually the type of stridor that kids present with can let you know where the source is. So if it's inspiratory stridor, it's usually extrathoracic, either glottic or supraglottic, meaning above the voice box. If it's expiratory, it's usually intrathoracic, such as tracheomalacia or tracheobronchomalacia. If it's biphasic, it's typically either at the level of the vocal cords, the glottis, or in the subglottis. Laryngomalacia is the most common cause of congenital stridor. You'll have collapse of the supraglottic tissues due to shortened aryepiglottic folds, as well as redundant arytenoid tissue, which will collapse into the airway. Parents will typically note that the stridor starts shortly after birth. It gets worse with feedings, it gets worse with agitation, it gets worse when they're sleeping, particularly on their back. It will typically improve if they're placed on their side or on their belly. 90% of the time, we do not have to do any surgical intervention for laryngomalacia. Kids typically outgrow this within 12 to 18 months. We do keep an eye on them during this time. Reasons that we will perform a supraglottoplasty in order to help this is if kids are having failure to thrive and are not feeding well, if there is any reported apneas, and we have a sleep study which confirms obstructive sleep apnea, or if they're having significant retractions or blue spells. On the left, we have a normal voice box or larynx. You see the epiglottis, the area epiglottic folds, and the arytenoids outlined there. On the right, this would be a child with laryngomalacia. You can see the arytenoids are tucked up underneath the epiglottis, and that's secondary to those area epiglottic folds being very tight. In the bottom right-hand picture, you can see that really tightly curled epiglottis. We'll call that an infantile epiglottis, and again, that's secondary to those short AE folds. The second most common type of stridor is secondary to vocal fold paralysis. This can sometimes be associated with a Chiari malformation, or if there was any surgical injury to the recurrent laryngeal nerve. Specifically, you want to talk and ask about cardiac surgery or a PDA ligation, as those are the most common causes of a unilateral vocal fold paralysis. Kids will have typically stridor at birth. It may be a weak cry, high-pitched, and sometimes they'll even have some biphasic stridor. Subglottic stenosis, as I mentioned before, anything in the subglottis typically will present with biphasic stridor. That's narrowing of the airway below the glottis. If they have a history of multiple intubations, this can lead you possibly to this diagnosis as well. And if we suspect any type of subglottic stenosis, we will take them back to the operating room, take a look with a rigid scope, and size their airway to see if this is present. Most of the time, we don't end up having to do anything for this other than observe, as this will typically grow with age. But if it is significant enough, either a tracheostomy in order to bypass this subglottic stenosis and eventual airway reconstruction will help to open up these children's airway. If a kid comes in with acute stridor, just like we talked about within the nose, acute rhinorrhea, that's on one side. If kids come in with acute stridor, you have to think about a foreign body. Persistent cough, stridor or wheezing, diminished breath sounds on one side. Sometimes foreign bodies that might be there for quite some time. You'll come in with chronic recurrent pneumonias. It typically affects the right lung more, just because the right main bronchus is a little bit more upright and vertical compared to the left, and so things slide down to the right main bronchus and right lung more easily. Foreign bodies are usually radiolucent. What you'll notice is hyperinflation on one side, atelectasis on the other. Epiglottitis is kind of something of the past. It's usually not that common, although with the increase of parents who are not vaccinating their children, this is becoming more of an issue. Kids will present with fever, drooling. They'll kind of be in a tripod position, meaning leaning over on their elbows, significant stridor. X-rays are sufficient for this diagnosis, and you'll notice a thumbprint sign on the lateral neck film. An immediate ENT evaluation is necessary, and if there is any question about the stability of the child, we will not do a scope at the bedside and take them straight to the operating room for likely intubation until they are adequately treated with antibiotics. Another form of infection that's similar to epiglottitis, just in a different area, is something called bacterial tracheitis. This is very common in kids that have tracheostomies, but in kids that don't have tracheostomies, this can be an acute airway emergency. They'll present with inspiratory stridor, pain over the neck. Typically, they'll have had a upper respiratory tract infection recently. About 50% of the time, we'll see this in association with the flu. On a neck film, it'll show irregularity to the lining of the trachea and sometimes show a membrane. Diagnosis is made by endoscopy, and typically we will take them back to the operating room, take a look at the airway, suck out any CAS or purulent material that might be there, and if necessary, intubate them for a short period of time. So, a few airway quick hits that I'm not going to go into detail that much, but if you notice expiratory stridor with feeding difficulties, think about a vascular ring. Those are going to be diagnosed on a CT. Pulmonary artery sling is always, if you notice a pulmonary artery sling, you have to suspect complete tracheal rings. About 50% of the time, kids with a pulmonary artery sling will have complete tracheal rings. Other causes of stridor or hoarseness can be laryngeal papillomas. Typically there will be a maternal history of HPV, as that is the cause of the papillomas themselves. They'll either present at a very young age or sometimes during their teenage years. If there is significant hoarseness and we diagnose a glottic web, which means a web at the anterior portion of the vocal cords, this can be associated with velocardiofacial syndrome. If a child was already diagnosed with velocardiofacial syndrome and you're not sure about their airway, refer them to ENT so that we can see if they do have a glottic web, as 60% of these children will have a glottic web. After adenotonsillectomy is performed, if there's immediate respiratory distress, typically this is picked up either immediately in the operating room upon extubation or in the postoperative area. This can lead to post-obstructive pulmonary edema, which the acute treatment is positive pressure. If you diagnose a kid with a bifid uvula in clinic, you need to think about that they might have a submucous cleft palate, and likely they will have then associated eustachian tube dysfunction. And if they're having recurrent ear infections, quick ENT referral would be advantageous. So that's it. Hopefully this was useful for your boards. I'm sure all of you will do well. If there are any questions, concerns, please feel free to get a hold of me. Again, my name is Matt Smith, and you can reach me by email here. Thanks so much.